So I'll have the first talk on introduction of ECMO and with clinical indications and the criteria when we think about it. So what I'm going to discuss is what is ECMO, why we need ECMO, when to think about ECMO, how to do ECMO, and post-decisional feasibility. If there's a separate chapter, so I will not be discussing much on that, and the indications. So ECMO is a temporary cardiopulmonary support that can be extended for a number of days to weeks. It is basically for a reversible cardiopulmonary failure. It's like a mechanical assist device. Most important intention is to give rest to the heart and lungs and to sustain the life till the time the heart recovers. So it's basically a modified form of heart-lung bypass used to treat acutely ill patients. Okay. Temporary but prolonged support for cardiorespiratory system and for other organs. It can be done outside the operation room. Take the blood from the venous system, oxygenate it, warm it, and return it back to the with the force to the artery. Completely or partially. And because it works for different pathways altogether, it able to give a heart and lungs rest. It unloads the heart and lungs and gives them rest, and that is helpful to recover them faster. In the life, in case of cardiopulmonary arrest, if you put a patient on ECMO, you will be able to sustain the life till the time you diagnose the problems and treat it. It provides oxygenation and removes carbon, so it helps in the gas exchange, it maintains the mean artery pressures, and it maintains the tissue perfusion. Now in critical case, we have ventilators, we have got inotropic agents, we have got IVP, and we have got other modes of measures like CRRV, cytokine removal, etc. But in spite of that, do we require ECMO? That's a basic question. The question is that in spite of all this, we see our patients dying. And most of you all agree with me that most of the time the patient comes with a single organ failure, but ultimately they deteriorates, they goes into multi-organ failure and they die. Hardly a few patients die because of the single organ failure. So what our patient usually dies of is the worsening and uncontrolled disease process. Either that's a very small quantity, most of them are because of multi-organ failure. Initially they show some improvement and then they go to multi-organ failure. Iatrogenic causes like unable to support them adequately and safely. That's the most important. You are not either you are able to support them adequately, but when you think about adequacy, you forget the safety. So it's going to be very difficult to balance the adequacy and safety. And what happens is in bargaining of support them adequately, we lose the safety and then we'll end up with ventilatory lung injuries. We'll end up with cardiovascular effects of high ventilator support, fluid overload, high dose of inotropic requirements, which leads to global tissue perfusions, hypothermia, and then secondary sepsis. And that's the reason probably most of our patients dies. So how does ECMO is going to help in this manner? It helps to sustain the life. It provides, it helps in gas exchange, maintain the mean artery pressure and tissue perfusion. And that's the reason you don't require to support them with the very high level of ventilator, very high inotropic supports. And that's the reason we can at least get rid of iatrogenic causes and help the patient to recover fast. So it will decrease the inotropic requirements, it will decrease the ventilator requirement, reduce the villi, rest to the lungs and rest to the heart. The dictum is to give rest to the organ which is affected, but in refractory IDS, refractory cardiogenic, so we talk a lot about giving rest, but we don't practice that because we go beyond the numbers. We want the saturation to be no more than 90, we want mean pressure more than 70, and in that bargaining, we let ventilator supposed to go high, let the inotropic level supposed to go high, and we keep on flowing our rate course. And that's the reason we require ECMO. Well, whatever we say has to have some evidence, and then we have separate talks on history and statistics that Nanda is going to talk on. So I'm not going on the details of that. We started basically, process we started in 1953. The first ECMO was reported in 1971. The question is ECMO beneficial? Beneficial, safety issues, efficacy issues, and the cost issues. So this is done in 1971, more than 75,000 cases have already been done now. The survival is between 50 to 80% with an ECMO, and morbidity due to ECMO per se is less than 5%. Morbidity because of complications of ECMO is less than 5%. So if you see about efficacy wise it is good because survival rate is around 50 to 80%. Safety wise is also good because of more complications because of ECMO per se is less than 5%. So when the safety wise it is safe. So ECMO is not a treatment by itself. It is a mechanical assist device. It's supposed it helps with the replacement therapy to sustain life, give rest to the organs, and maintain adequate perfusion and oxygen. So ECMO, as I say, is a bridge. It's a bridge to recovery, or this is chronic failure. Is a bridge to mechanical assist device, cardiac and lung, or it is bridge to a transplant. So remember that for ECMO to be initiated, there has to be some end goal. So ECMO can be used in all the ICUs, ICU, medical ICU, surgical ICU, emergency rooms, neurocritical cares, neonatal and pediatric ICU, and even the transplant ICU. So it has got utility in all the ICUs. In respiratory care, it is usually for acute life-threatening, reversible, unresponsive to the conventional and alternative therapies. Then you can think of ECMO. It is used for both oxygen failures as well as ventilation failures. So anything which leads to an acute respiratory failure, disease, airway disease, or even pulmonary vascular disease, you can think of ECMO is an acute and reversible. And usual criteria is when the PFS is less than 75, oxygen is more than 30, Murray score is more than 3, or A grade more than 600, or person is hypercapnic with a pH of less than 7.2 for more than 3 hours. You can think of it. Most important is, okay, what is most important is within 4 weeks of after your maximum medical assistance. So when you put the patient on ECMO, you see how the patient is improving. If he does not respond in that 4 or 6 hours, we should start thinking about ECMO. Because once you think about ECMO, initiating on ECMO is going to take a longer time. So it might even take around 24 hours for you to mobilize the things and get the consent from communities. If you don't have your own setup, you organize things from outside, that takes time. Start thinking about ECMO. So you have to see how the patient is progressing. If your patient is responding to your conventional therapies, you try conventional ventilation, not improving, you try the advanced mode of ventilation, that is also not helping, then you can start thinking about ECMO earlier. Excluding when there is which is non-coronal failure, again the ECMO may not be of much benefits, so you should not think about that. ECMO in acute on chronic respiratory failure. Here there is some difference basically because the patients with chronic respiratory failure, and we know that if we put the patient on ventilator, that is going to further worsen the chronic lung status. So in that case, it's preferable to put the patient on ECMO instead of putting a patient on ventilator, and then you can think of putting the patient on ECMO plus the BiPAP, and that might help the patient more. And this is the survival statistics in 2017 ELSO statistics. It shows in acute pulmonary adult pulmonary failures, the survival rate is around 65, and the patient which will be discharged after is around 57%. So an overall survival is of the patient is 56%. 86,000 cases in registered in ELSO. ELSO in ICU, cardiogenic shock refractory to conventional therapies, refractory arrhythmias, cardiogenic shocks can be secondary to acute MI, decompensated cardiomyopathies, myocarditis, okay, all that can be think about. Okay. Both of cardiogenic shock is beyond business. We always immediately try to raise the cardiac output by into the tissue perfusions, maintain the organ functions until the early remodeling takes place, and improve patient outcome in the late phase. So what is most important is not only the cardiac output, but again the tissue perfusion is also most important. So whenever you think about ECMO as an indication for a cardiac, not only the mean blood pressure has been considered, but even the lactate levels in the venous saturation is essential because that will tell you about the tissue perfusion. So when you should think of ECMO, when the mean artery pressure is less than 70, the pediatrics and neonates less than 55-40. When the venous saturation is less than 70 or the lactate is more than 4 millimole, you should think of, because the testing of is not good, or when the inotropic score is more than 20, you should start thinking about using it. So you should think of ECMO, cardiac ECMO, before it goes to an irreversible shock or because patient becomes too much acidotic. And second, before the second organ start getting failed, you should think about it. University of Michigan, there's a criteria of putting the patient on ECMO is when the cardiac index is less than 2 liters per step. Metabolic acidosis, gas excess is more than -5. And patient developing oliguria or urine output less than 0.5 ml per kg per hour for 3 hours. That means that this is not adequate and you should start thinking of ECMO. In University of Michigan, there are some relative contraindications to put the patient on cardiac ECMO, and that is the condition with a very poor outcome. When there is a prolonged shock with the metabolic acidosis, gas excess is more than -5 for 12 hours. Okay. Oliguria for less than 0.5 ml per kg per hour for 12 hours. These are the cases which even if you put down a patient on ECMO, the outcome is going to be not great, going to be dicey. And that's the reason that becomes a relative contraindication. But probably, I think we start thinking about ECMO only at this stage, and that's the reason probably we are not getting very good outcome with an ECMO. So there's a prolonged hypotension, again, ECMO is not going to be helpful. So anything which is potentially reversible myocardial dysfunction can lead to acute myocarditis or post-transplant rejections or dilatory cardiomyopathy. And if you see the survival in cardiac cases, in pediatric survival is around 50% the cardiac patients post-cardiac, and in adult it is around 40%. The main reason for less outcome in adult cardiac is basically most of the adult cardiac ECMOs are secondary to coronary artery disease, and if the patient is got an infarct and the revascularization has been delayed, then you have a patient with a dead myocardium, and that's the reason they don't recover fast. And in that case, you should have a backup like assist device or with the facility of transplant in instant. So ECMO in medical ICU, it can be used in septic shock, can be used in poisoning, can be used in hypothermic coagulopathy. ECMO in septic shock, it's a difficult substrate to start with. There will be a lot of capillary leak. It's going to be difficult to balance the fluid setters because there will be a lot of capillary leaks. You will end up having a lot of fluids. So initially, when you are starting with an, I will not advocate that people should think of ECMO in a sepsis to start with initially. ECMO for hemodynamic supports is required. Outcome survival in adults is around 20 to 30% with an ECMO in sepsis. In pediatrics around 50%. Neonatal is better, around 70%. And you can think of ECMO using in dengue with malaria, with ARDS or typhus or any infective etiology. ECMO in poisoning has got a good outcome. ECMO can be used in calcium channel blockers, overdose, beta blockers, CELPHOS poisoning, econite poisoning, any cardiotoxic seeds poisoning, insect bites, and scorpion bites. The individual cases been reported with the patient was put on ECMO. I think in 2013 we have a training course in Delhi, and that time the north there was a lot of CELPHOS poisoning in north, and there was some discussion whether the ECMO is going to be helpful in CELPHOS poisoning or not. One of the delegates at that time, Dr. Vivek Gupta, was there in the team, and he has taken this as a project, and then he done a lot of cases on ECMO in CELPHOS poisoning, and they found very good results. Almost the survival in his study, this is only a study which I from August 2013 to May 2014, but then he has done few more cases. He has close more than 70 cases he has done, and almost the survival rate around 70%. So that is a good substrate, and then I think some people in Surat also they are doing a lot of cases, and they also similar survival rate around 60 to 70% survival rate with ECMO and poisoning. So it's a good indications of CELPHOS poisoning in case of and usually the stay with of ECMO in the CELPHOS poisoning only 5 to 7 days. So most of the patients either require 5 to 7 days or death. So this is not a prolonged ECMO. Definitely you can think of using ECMO in CELPHOS poisoning. I'll not go in detail because there's a separate lecture on this. ECMO for hypothermic coagulopathy. There is rapid access bedside thermotherapy. So usually when the patient comes in a shock state with you, and when the patient is cold and hypothermic, usual manuals to improve the hypothermia is you give surface warmers, blankets, but they all are going to be difficult because there is a very poor circulation, so that is probably not going to help much. In that case, you can think of a short ECMO, where you can put the patients on ECMO, venous ECMO. So you don't have to put a very large bore cannulas. You can put a small bore cannulas, 17 French and 21 French. Okay. You have to use ECMO for very short time, so you don't require a coated circuit or central, PMP oxygenator. You can even use a simple oxygenator, which can be primed bedside. You flow recommended on 3 to 3.5 liters. You don't used to use heparin because patient is already in COVID, which you don't require heparin also in that case. The target is to reach normothermia in 30 to 45 minutes, maintaining for 20 to 30 minutes. And once the patients reach to a normal temperature, the coagulopathy also start getting settled down, and then you can think of getting the ECMO out within say 1 to 2 hours of time. Once the temperature reaches more than 36, the bleeding stops, you can take the cannulas out, and it can be an ICU procedure. ECMO is surgical ICU. It can be used for pre and post cardiac surgery for stabilization of the patients, and so post cardiogenic shock, pump heart, pump lung, congenital heart disease, the pre-cardiotomy dysfunction. So put the patient on ECMO, stabilize the patient, and then take for the cardiac surgeries. The usual cause for myocardial dysfunction after cardiopulmonary bypass is the inflammatory response, myocardial ischemia because of the aortic cross-clamp times, hypothermia. Most of the time is the refractory injuries, or it can be inadequate myocardial protection during the cross-clamp times, and or there can be ventriculotomy, and that is direct injury to the myocardium, and that takes some time for them to recover. Again, the indications to the criteria remain the same for thinking about ECMO. Then you can think of ECMO putting an ECMO is another indication is ECMO, that is elective ECMO in a complex tracheobronchial reconstruction surgery or tracheobronchial injuries. Okay. So you have a complex tracheal reconstruction, complex bronchial repairs, cardiac shunt procedures, bronchial alveolar lavage. So in that case, you put the patient on ECMO, VV ECMO. You don't have to, you may not intubate the patient, or you just put the patient on oxygen. Initially, you might have to think of VV ECMO when you want to do corrective surgery, but then you can think of keeping only on the VV ECMO also. So it's an elective procedure where you are expecting it to be a difficult tracheobronchial injuries to be managed with. ECMO in neonatal ICU. Again, this is going to be discussed in pediatric and neonatal ICU as separate topics. I'll just go through question fast. Same, the indications remain, qualification criteria is going to be there. Same, mostly in neonates they consider the OI as a condition to be thought of. And you can think of ECMO starting with the OI is more than 25, and you can definitely put the patient on ECMO once the OI is crossing 30. So once you think about when there is a failure to respond to maximal therapies, you can start thinking putting the patient on ECMO. So you can use it in 50HN. Only contract is it, there is a prematurity, low birth weight, less than 2 kg, because you don't get the proper size cannula for that. I need intraventricular hemorrhage for grade 3, grade 4, coagulopathy, and the patient is ventilated for more than 7 to 10 days. Again, this is going to be discussed in separate. If you see the maximum experience, if you see with neonatal cases being done on ECMO, if you compare the pediatric and adult ECMO, the neonate has got the maximum experience, and there is a good results. Survival rate is much better as compared to the pediatric and adult ECMOs. Just keep this slide because we are going to discuss this as separate topics. Then ECMO can be used in emergency room as an ECMO ECPR. That's an extracorporeal cardiopulmonary resuscitation. So that is also known as rapid deployment of ECMO. Use of ECMO as a rescue for a failed standard cardiorespiratory pulmonary arrest (CPR). The basic goal is that you should be able to cannulate the patient within 30 minutes of arrest. So there are two things as to work. One is doing a CPR, where to continue the CPR till the time you are able to cannulate and initiate an ECMO. So it's always that important that if the patient does not respond in first 10 minutes of CPR, then your ECMO team should be activated. They should start coming in, be preparing themselves, and if they don't respond, then you should start cannulating the patients. But it has to be done in 30 minutes. And the survival rate in pediatrics and around 28 to 30% in adult patients. So this, otherwise this patient would have definitely died, but you can still, and with a good, reasonably good neurological outcome if you have done a good CPR and if you have been able to start within 30 minutes of arrest. So I'll not discuss on this because there's a separate talk on this. So you can think of ECMO in transplant ICU. It be used for a donor also and for recipient also. It can be used for both. For recipients, this is going to be ECMO can be used as a bridge. So patient waiting for a transplant and he deteriorates, you put the patient on ECMO till the time you get the organ and do a transplant for a heart and lung transplant. It can be used as support during the surgery. So instead of taking the patient on cardiopulmonary bypass for during the surgery, you can put the patient on ECMO, complete the surgery, and then continue the patient on ECMO for surgery. Or it can be used for the graft dysfunctions. So it can be used for lung and heart both. Again, this is going to be a separate talk on transplant. So I'm not doing that topic. It can be used for donor also, for heart beating donor, non-heart beating donor, and something known as ex vivo lung perfusion. So non-heart beating donor, what happens if the patient is end-stage disease and is going to die, and if you don't have a retrial team who can come and retrieve the organs after the death immediately, you can put the patient on abdominal ECMO so that you can preserve the abdominal organ after the patient dies, and then that organs can be retrieved. And once the team comes for the retrieval of the organs, and you can preserve the organs in a better way. So that is known as something known as extracorporeal internal support for organ retrieval. So you're supporting the patient for an organ retrieval so that you can have a better condition of organs. Patient is already on ECMO and he deteriorates and becomes the donor. Brain dead donor becomes unstable. We are waiting for getting the consent, organizing the team, and in between they become deteriorated. You can think of putting the patient on abdominal ECMO and maintain them. Donation after withdrawal of care. And there's something else ex vivo lung perfusion. See, the problem with the lung transplant is that once you remove, take the lung out, the whole ischemic time is less than 6 hours. So if it's not been transplanted within 6 hours, the outcome is not going to be good. Ideally, within 3 to 4 hours. So you can do is something known as reverse ECMO. You can, if you want to transport these lungs for long distance, you can put the lungs on ECMO and do a reverse ECMO, and then preserve the lungs before you can transplant the lungs. So in short, we require ECMO for each and every support the transplant unit, and that's the reason it is mandatory to have a ECMO if you want to have a transplant centers. Let's talk about the components of ECMO. These are the hard bits of ECMO. This is we are going to discuss in the afternoon session when we discuss about the practical parts. These are different pumps. Centrifugal pumps, soaring. This is just a magnetic pump, and this is a metronic pump. Oxygenators. This is how the circuit is going to look like. Cannulas. The question is how much time or how long the ECMO can be run. Basically, till the time the heart and lung recovers sufficient enough to maintain the blood gases at moderate support. So you don't require to wean off the ECMO till the time the patient recovers completely. You know, once they start maintaining on moderate support, you can think of getting the ECMO out. Till until some insult comes, like brain dead, patient massive hemorrhage, you might have terminated ECMO earlier because the condition is not salvageable otherwise. And most important in Indian scenario is till the patient's relatives permit, because then it's a financial issue also. Average ECMO run is around 8 to 10 days of ECMO. Patient can remain on ECMO for extended period of time. Longest which I written is 121 days. That was an old. Now people have kept the ECMO for more than 300 days also. Our center has kept the ECMO on ECMO for more 51 days. The course history I am going to discuss as a separate topics. But this is the ECMO when it was started in 1971, and you have ECMO like this in 2008, where the people opt for an ECMO rather than be on ventilator. This was a case inspired me when I was been to Taiwan. Taiwan is almost an economy which is, when we started ECMO, we started in 2007 ECMO. And at time we thought that the ECMO is going to be very difficult in Indian scenario because of the post and everything. And we went to US, Dr. Goel been to US first, and we found out that there's meticulous monitoring every 1 hour, reporting everything. So that becomes a very costly issue. Then I happened to be to Taiwan, where the economy is almost like ours, and they have minimized the programs to a great extent by limiting the investigation. They try to make program more economical. That time they just told me about one case where there was a person with an infected endocarditis with platelet vegetations, aorta RF fistula and ventricular septal perforations beneath the tricuspid valve. And when they took him for a corrective surgery, they found it's not correctable. They done his cardiectomy. They put the patient on ECMO, giving the heart. Patient came out with the OT with these parameters. Patient remained without the heart for 16 days. Then they got a heart. They transplanted the heart, and that patient is doing very well. This is just to tell you how ECMO can be helpful. Okay. In Taiwan, when I asked them, they say usual they make an ECMO is a national program. So ECMO is a free of cost to the patient. It has been treated free of cost, and they have a lot of organ donation motivation. And almost most of the country people they sign for an organ donation. And all brain days. So usually they say in average time they get an heart is around 10 to 15 days they get one organ heart in the institutes. So that's you can think of keeping the patients for 10 days, 15 days without heart and think of transplant. So ECMO is a medical thing. It's an exciting exercise. For it works requires expand multidisciplinary approach. So you can think of the Moore score of more than 3, FP or FR less than 100. You can think about it more. What the ideal candidate is acute disease, reversible condition, no comorbid factors, minimum ventilator supports been given before that, and then the predictor mortality is without ECMO is going to be more than 80% can think of ECMO. This is most important, I think, is initiate ECMO. You should consider ECMO when the risk of mortality is less than more than 50%. So when the PF risk is less than 150, you should start thinking about ECMO, because in that case, definitely by the time the relatives agrees, you organize the team, everything, it takes some time. So before the patient goes very bad, you think of ECMO. And if the patient improves, definitely you can skip the ECMO. But you should think about ECMO before that. And when ECMO indicator, then the PF risk goes to less than 50. Similarly, in cardiac status, think about ECMO when the level is more than, inotropic score is more than 420 or lactate levels are more than 4. And definite ECMO, you can think when the inotropic scores more than 4. But most important I want you to remember is ECMO is a bridge to recovery or to transplant. A bridge to nowhere is not at all a good idea. So ECMO is not to prolong death, it is going to be prolonged life. Don't have any further destination. And the